Hi, Michaela from OT.
Hi, Kiefer from PT.
Can you tell me the difference between the PEOP process and model?
Well, lucky for you, since I'm fresh off the grad program, I'll tell you all about it. So the PEOP model outlines the intricate relationship between person, environment, and occupation factors to elicit occupational performance. The model proposes that when an individual participates in occupation, they influence themselves and the environment. This model serves as a tool to provide logical intervention planning for us and to involve the collaboration with our client to determine if the outcomes and goals that we've developed are meaningful and valuable to them. The model proposes that the client's context and preferences shapes the goal for performance, participation, and well-being, which are all defined as parts of health. And this model proposes that there must be a person-environment fit to successfully bring about the occupational performance, participation, and well-being. The process of the PEOP builds upon the model and moves through a succession of stages within the process to elicit occupational performance from the client. This process is considered a top-down approach because it assesses performance and participation first before ever considering the person and environment factors. First, through obtaining the client narrative, the therapist creates past, present, and future perceptions, goals, and interests, and goals that are unique and meaningful to the client. The narrative usually tells a story about the client's life, and through assessment and evaluation, the client's current status is measured along a continuum of capabilities ranging from constraints and barriers to indicate potential weaknesses of the client, along with capabilities and enablers that may be used as strengths for their intervention planning. Intervention planning involves outlining strategies to bring about outcomes that are in alignment with occupational performance, participation, and well-being. These interventions are discussed in broad categories, including create and promote, establish, restore, maintain, habilitate, modify, compensate, prevent, educate, consult, or advocate. These outcomes should be measured to evaluate our client's improvement in therapy, but also to contribute to evidence-based practice in the future. For example, I'm getting ready to go see Travis, a 55-year-old male, on the general medical floor. He's here for IV antibiotics following a wound dehiscence following a CABG surgery. He's 2 weeks post-op, and his cardiologist told me that the reason why he's back as an inpatient is because he broke his sternal precautions and opened his wound after dropping a cigarette on the ground. Crazy, right? So I hope to use the PEOP process to obtain his narrative, and I hope that his narrative will tell me about his interests and perceptions on his current condition and environment, and hopefully that he will share some goals with me so that he can return home. I imagine that in my assessment I will indicate his ADLs such as bathing and dressing, and IEDLs such as driving and smoking that may serve as barriers to him at the moment, because I imagine he's in a great deal of pain. I hope that I can channel his stubborn, motivated personality that I've read about in my chart review to utilize it as a therapeutic use of self and strength for himself. Through that, I plan to come to agreement with Travis on some intervention strategies that will educate him in continuation of proper sternal precautions and wound care for him to prevent any future scenarios such as this from occurring again in the future.
Wow, Michaela from OT, that's really complex. That's a lot of stuff that you need to know. I think I'm just going to stick with PT.